Today, we're tackling trigeminal neuralgia, TN. It's known as one of the most intensely painful conditions that someone can experience. You might have heard it called actic douloureux, or even, quite starkly, the suicide disease. So our goal here is to, cut through the complexity pretty quickly. We want to really get into the specifics of the pain, what makes it feel like a lightning bolt, right? And address the critical challenge of diagnosis, especially telling it apart from common things like TMJ. And then we'll look at the treatments, both meds and surgery.
That framing is spot on. We're talking about a chronic neuropathic disorder. It affects the trigeminal nerve, which, is the main nerve for sensation in your face. And the sheer severity of these attacks, it often leads to serious anxiety, even depressive disorders. So getting that diagnosis right and quickly in the whole craniofacial pain area, it's not just about pain relief. It's really vital for the patient's overall well-being.
Okay, let's start there. The unique signature of TN. When we talk about this condition, what is that pain? What makes it so different?
Well, its core identity is its paroxysmal nature. Think sudden, severe, almost like a short-circuiting electrical feeling. It's typically recurrent unilateral, so one side of the face. That's 97% of cases. And patients describe it as shooting, stabbing, or most often like an electric shock.
And the duration is key too, right? It's not a constant ache.
Exactly. A single attack, a paroxysm, might last just a fraction of a second, or maybe up to 2 minutes. Brief, yes, but utterly devastating in intensity, and they can cluster together, unfortunately. So over time, these clusters can stretch into hours of really intense suffering for the patient.
Location matters too, I imagine. You mentioned the trigeminal nerve. It has those three branches, V1, V2, V3. Where does the pain usually hit?
Typically, it's the lower two divisions. So V2, the maxillary branch that covers your upper lip, cheek, side of the nose, and V3, the mandibular branch, is the lower jaw, chin, lower lip area. It's actually quite rare for the pain to be only in the V1 branch, which is the forehead and eye. And the fact that the pain follows those specific nerve pathways, that really helps the clinician figure out the source.
Okay, but the most maybe startling thing for people learning about this is how these attacks get triggered. What sets off that shock?
Almost nothing, terrifyingly. The triggers are usually completely innocuous stimuli, things like just a light touch on the face, shaving, chewing, talking, brushing your teeth, even applying makeup, or sometimes just a cool breeze hitting the face.
Wow.
Yeah. And you can see why patients become incredibly anxious about, just normal daily activities or changes in their environment. But an important point is these attacks very rarely happen during sleep.
Right. Okay, so we have this signature electric shock pain. How do we categorize the causes? What's actually causing this structurally?
So we generally look at three main types. The most common is classical TN, or primary trigeminal neuralgia. This is the one responsible for that classic shock-like pain. And the cause, it's almost always a vascular neural conflict.
Vascular neural conflict. Oh, sounds like a bit of a war between a blood vessel and a nerve.
That's actually a great way to put it. It usually means a blood vessel, often a pulsing artery like the superior cerebellar artery, is pressing chronically on the trigeminal nerve root right where it enters the brainstem. And this constant physical pressure damages the myelin sheath. That's the nerve's insulation, basically. When that's damaged, the nerve fibers can misfire, sending out those hyperactive, shock-like signals.
Okay, that makes sense. What are the other types?
Well, then there's secondary TN. This is caused by some other underlying condition or structural problem. Multiple sclerosis is a known one. Maybe 3 to 4% of TN cases are linked to MS, but also tumors, cysts, sometimes trauma or injury.
And what about that old term, tic douloureux? Does the pain actually cause a facial tic?
It often does, yes. Tic douloureux literally means painful tic. When the pain hits its absolute peak intensity, it can trigger these involuntary contractions or spasms in the facial muscles on that affected side. And sometimes you see mild autonomic symptoms along with it, like the eye tearing up or the skin getting a bit red on that same side.
And finally, there's the atypical form you mentioned. How is that different from the sharp, quick shock?
Right, that's TN with concomitant continuous pain. It's often, maybe less intense than the shocks, but it's much more chronic. It feels more like a persistent, dull ache, or maybe a throbbing or burning sensation that just lasts for long stretches. The really difficult part is that this chronic ache often happens alongside the sudden, severe shock-like attacks. So patients get this double whammy, constant background pain, plus these intermittent lightning bolts.
Okay, this leads us straight into a really critical point, especially for diagnosis in primary care settings. Telling TN apart from temporomandibular joint dysfunction, or TMD. TMD is super common, causes facial pain, jaw pain. Why is it so easy to mix these up? And why is getting it right so incredibly important?
It's crucial because the treatments are completely different. You absolutely don't want to be treating TN with, say, dental work or typical TMD therapies. That's just wrong. The key to telling them apart isn't just where it hurts, but the pattern and the triggers of the pain. Let's look at the classic differences first. For classical TN, remember, the pain is acute, piercing, stabbing, lasts seconds, maybe minutes, and there are often long periods where the person feels fine, in remission, whereas TMD pain, usually continuous, dull, kind of diffuse and aching. And it lasts much longer, often several hours, with maybe only short breaks.
So that duration difference is huge. Seconds versus hours.
Exactly. And the trigger, that's probably the biggest clue. TN gets set off by those trivial things, the light touch, the breeze. TMD pain, on the other hand, is usually related to function.
Yeah, meaning
It's linked to things like prolonged chewing, clenching your jaw, grinding your teeth, excessive activity of the jaw muscles. Plus, TMD pain doesn't usually come with those specific tics or the tearing you sometimes see with TN.
And you mentioned timing earlier, too.
Yes. Another big difference is nighttime. Classical TN pain almost always goes away during sleep. People get a break. But TMD pain, which can be related to nighttime grinding or muscle tension, well, that might still be there when you wake up.
Now let's circle back to something you flagged earlier, that nuance with secondary TN. You said that can really muddy the waters diagnostically.
Oh, absolutely. It's a major diagnostic pitfall. That continuous duller pain you can get with secondary TN, say, from a tumor or MS, can actually feel quite similar to the long-lasting continuous pain of severe TMD. So if a clinician just assumes any continuous facial pain must be TMD, they could completely miss a serious underlying issue, like a brain tumor or MS. That's why neuroimaging, usually an MRI, is so critical if the pain pattern isn't that classic electric shock. It's a vital screening step.
Interesting. Any other clues?
Well, sometimes temperature response can offer a hint. TMD pain from muscle tension often feels better with heat, but secondary TN pain might actually feel worse with heat. It's a complex picture to sort out.
Definitely sounds like it. Okay, so given how agonizing this is, effective, fast treatment is obviously the priority. What's the first line of defense, pharmacologically speaking?
The cornerstone medication, the first-line treatment pretty much everywhere, is an anticonvulsant called carbamazepine CBZ for short. Its job is basically to stabilize that overactive nerve.
Can you break down how it works? Stabilizing neuronal activity. What does that actually mean for the nerve?
Sure. Think of that trigeminal nerve again, like an electrical wire with frayed insulation, right? It's short-circuiting, firing uncontrollably. CBZ works by blocking certain channels in the nerve cell membrane, specifically voltage-gated sodium channels. So it's essentially putting a speed limit on the nerve's electrical signals. It dampens the nerve fiber's ability to generate those wild, hyperactive impulses that cause the shock sensation.
Okay, that makes sense. Putting the brakes on the nerve firing.
Yeah.
How well does it actually work for pain control?
Initially, it can be quite effective. Studies show, on average, about a 68% complete or satisfactory response rate. That means a good reduction in how often the pain hits and how intense it is, usually measured over 2 to 6 months. And we also know that higher doses, typically 800 milligrams a day or more, and sticking with the treatment longer, say for 6 months, might lead to slightly better results in managing the pain.
But taking a drug like this long term, that raises big questions about safety and side effects, doesn't it?
Absolutely. And clinicians really need to monitor patients closely. There are common side effects like dizziness, drowsiness, maybe blurred vision, but the serious ones demand real caution. We're talking potential blood problems like low white blood cell counts, liver toxicity, and severe allergic reactions, including something called Stevens-Johnson syndrome, which is a very dangerous skin reaction. And importantly, we can't ignore the potential, though rare risk, of increased thoughts of self-harm or suicide. It links back to just how severe this condition can be, historically and currently.
So if CBZ isn't an option, maybe due to side effects or if it stops working over time, what are the next steps for medication?
Well, there are several second-line options. Oxcarbazepine is one. It's structurally similar to CBZ, but might have a slightly better side effect profile for some people. Then there are drugs like gabapentin and pregabalin. Sometimes a muscle relaxant called baclofen is added, often in combination with these others. But it's really crucial to understand that standard opioid painkillers like morphine or oxycodone, they're generally not effective for the typical sharp, shock-like pain of TM.
Okay. What about those really acute, unbearable flare-ups. Someone ends up in the ER in agony. Is there anything for immediate relief?
Yes, and this is where we see a really significant recent development highlighted at the AAN 2025 meeting, the IFT study. It looked at using intravenous phosphonatoin, or FPHT. This offers rapid relief in those acute situations without needing surgery. The study showed that something like 90.9% of patients got at least a 50% reduction in their pain score within just 2 hours of the first dose. That's potentially a real game changer for managing these crises.
Wow, that fast relief is huge. Now, let's talk about patients where medications just aren't cutting it, the refractory cases. What's considered the surgical gold standard?
That would be microvascular decompression, or MVD. Now, it is the most invasive option. It's major brain surgery. But here's the critical difference. MVD is the only treatment that tries to fix the underlying cause, that physical compression. It's not just trying to block the pain signal, it aims to resolve the root problem.
Can you walk us through that procedure? How do they actually separate the blood vessel from the nerve?
Sure. It involves making a small opening in the skull behind the ear. The surgeon uses a microscope to get a really close look, finds that spot where the artery or vessel is pushing against the nerve root, then very gently they separate the vessel from the nerve. And they insert a tiny soft pad, it's often made of Teflon felt, between the vessel and the nerve. This cushion stops the constant pounding or pulsing damage from the blood vessel.
And does MVD live up to that promise of long-term relief?
Generally, yes. It offers the best chance for long-lasting relief with the lowest likelihood of the pain coming back. Around 90% of patients get significant initial relief, and about 73% are still pain-free 5 years later. And importantly, the goal is pain relief without causing new facial numbness, which is a risk with other procedures. But it is major surgery, so it carries risks. Things like hearing loss, though that's less than 1%, stroke risk around 1%, and a very small risk, about 0.15% of permanent facial numbness.
Okay. So for patients who either aren't candidates for MVD or choose not to have major surgery, what are the alternatives? You mentioned procedures that intentionally damage the nerve.
Right. Those are often called destructive procedures, though maybe ablative is a better term. The goal is to disrupt the pain signals by intentionally damaging the nerve fibers. One option is stereotactic radiosurgery, often called gamma knife. It's non-invasive, uses focused radiation beams. It has a high success rate, but the downside is the relief is delayed. It can take weeks or even months to fully kick in. Then you have the rhizotomy procedures. These are usually done percutaneously, meaning through the skin with a needle. Options include radiofrequency ablation, balloon compression, or injecting glycerol. These damage the nerve root to stop the pain signals. They offer much more immediate relief than a gamma knife, but there's always a trade-off. They invariably cause some degree of facial numbness or altered sensation. And the relief, while immediate, is often temporary, maybe lasting a few years before the pain potentially returns.
So it really sounds like a complex decision for the patient, weighing the invasiveness and risks of MVD, but its potential for long-term sensation-sparing relief against the quicker, less invasive, but temporary and numbing effects of the rhizotomies or radiosurgery.
Precisely. It's a very individualized decision based on the patient's specific situation, health, pain pattern, and tolerance for risk versus benefit. And we shouldn't forget the adjunct treatments either.
Right.
Things like botulinum toxin injections, sometimes acupuncture. These can play a role. And crucially, psychological support and sometimes specialized physiotherapy for related muscle issues are really important parts of managing the overall condition and its impact.
Okay, let's try and tie this deep dive together then.
Well, I think the key takeaway is that managing TN demands really careful diagnosis first. You've got to distinguish that unique paroxysmal shock-like pain, especially from conditions like TMD that present with more continuous aching. And then the treatment strategy. It's always a balance. Balancing the effectiveness of first-line drugs like carbamazepine against their significant side effect potential, or weighing the high long-term success of MVD against the real risks of major surgery. It's complex.
And you've really underscored just how immense the psychological burden of TN is. That constant fear of the next attack, the severity of the pain. It pushes people into social isolation, it causes deep distress. So maybe the final thought we can leave you, the listener, with is this. We know TN was historically called the suicide disease because of its severity, and we know even the best treatments can sometimes lose effectiveness over time. So thinking ahead, beyond just stopping the pain, how do we better help patients manage that profound chronic psychological weight of living in constant fear of the next shock? What kind of long-term, maybe neuroplastic approaches could address that aspect? Something to mull over. Thank you so much for joining us for this deep dive into trigeminal neuralgia.